Dear ladies and gentlemen, dear colleagues and friends, dear chairman of the webinar, it's a great honor to speak here today. A very warm welcome from my side, from Germany, to the colleagues in Pakistan. I'm Peter Schwarz. I'm a professor for prevention and care of diabetes, and I'm the president of the International Diabetes Federation. And what I would like to do with you is to discuss about modern strategies in diabetes care, but also to discuss what we can improve to deliver a better quality of diabetes care and how we can use the pharmacotherapy what we have available in combination to improve the outcome of our patient and to improve the quality of care for people living with diabetes. So bridging glycemic variability and durability with sitagliptin and metformin, scientific perspective of art of care of diabetes. And I think this is actually a nice slogan, art of care, because in some instance, we are artists as physicians because we have to modify specifically our pharmacotherapy based on the need, on the circumstances, on the physiology and pathophysiology of our patients. And to choose the right approach, this is one of the challenges we have to address. So again, a very warm welcome from my side to you. And what is driving me as president of the International Diabetes Federation, that I truly believe that people living with diabetes deserve a better quality of life, deserve a better quality of diabetes care. Here, the objectives of our webinar, it is mainly going into it, what can we achieve by combining medication? What can we achieve by um, uh, developing a polypill concept? And what can we achieve by acting early in the right manner in terms of outcome for people living with diabetes? And I want to introduce this concept and then discuss with you certain pros and cons of the concept and will be available later on, even if this is a recorded lecture, later on also for questions for you. What is the reality today in terms of diabetes prevention? We could say we have failed in some instances because 589 million people living with diabetes shows the latest release of the IDF Diabetes Atlas, what we have released in Bangkok a few weeks ago. But WHO is talking about 800 million, and this year about 830 million people living with diabetes. So what does this mean? Yeah, there are two big organizations, two different numbers. You could say it makes no sense, but actually both are right, but both use different criteria to diagnose diabetes. But if we sum this up, it's urgent call to action that we have to do something to prevent diabetes, to earlier diagnose diabetes, to better treat diabetes, and to think about remission of diabetes. Because where are these people living? In low and very low income countries. So it's in your environment in Southeast Asia. This is Banshi Jabu from India always tells me I should not use this term, but it's at the end the capital of diabetes in the world. 83% of people living with diabetes come from Bangladesh, Pakistan, China, and India. So four countries summarizing the biggest group of people living with diabetes. So if we really want to have an impact on lowering the prevalence of diabetes, we have to have it in your environment. And if we are going to Pakistan, it's one of the highest prevalences of diabetes. With 30.8%, I personally believe it's actually slightly higher because the numbers we give today are based on studies which sometimes are 10, 15 years old. So very high prevalence, a high number of people in the country living with diabetes, and also a higher rate of undiagnosed cases of diabetes. So this is something we have to change. Getting the undiagnosed cases, we could argue what is more important, better treatment or a lower rate of undiagnosed cases? It's difficult to say because by diagnosing diabetes, the patient has the opportunity to get a treatment, and this will be directly of benefit. But having a better treatment for them will push and they will generate synergies in improving the outcome. This means we have to understand where diabetes is coming from. And here, an unusual slide. You might say it shows the prevalence of diabetes in the upcoming years, so in Africa and Southeast Asia, but it is not. It shows the conjunction of prevalence of type 2 diabetes with air pollution. So air pollution is becoming a relevant determinant for diabetes care in the future. If we stand behind a running diesel engine and we take some deep breaths, you might find medium-sized particles out of the diesel engine 2 weeks later in the insulin-producing beta cell. So the imagination is it's a disaster. We don't know what it means for diabetes in humans, but in cell culture, it impairs insulin secretion by 30%. It's not only relevant for beta cells, it's also relevant for other endocrine cells. So air pollution becomes a determinant. But if I ask you what is the main determinant for diabetes development, it's fried carbs. If you fry carbs at a temperature above 130 degrees, you build bonds between glucose and fat. And you eat them. And because it looks tasty and it tastes good. And so, but what happens with this bond? The body needs a lot of energy to break it down. And the body will not use this energy to break it down if there's a continuous influx of energy, like it is normally in our lifestyle. So the body is storing this. And where is he storing it? In the liver. And this is muffled, this is mesh. This is the easiest way to understand how fried carbs and fried products generate accumulation of fat in the liver. And this is the strongest progenitor for the development of diabetes. So, especially in Southeast Asia, people living with diabetes or people developing diabetes risk are slim but have liver fat and visceral fat. But the main driver is the fat in the liver. If you have 100 grams of fat in your liver, you become a non-responder to physical activity. That means you might do physical activity, but it doesn't work. And this is I apologize for using the word, this is the devil if we are talking about diabetes development. And this is what we have to address if you really constantly and sustainably want to prevent diabetes from developing and lead to a remission. So therefore, prevention again, this is what is important, and this is what we have to focus on. And these two numbers give you a measure for prevention of diabetes. Walking 10,000 steps nearly prevents any chronic disease from developing. But if you have diabetes and you walk only 1,000 steps more per day, and it doesn't matter how much you start, the 1,000 steps more lower the postprandial blood sugar by 1.5 millimole. And this is twice as much as 1,000 milligram of metformin are doing. So this physical activity is actually very, very cool to be used to lower diabetes risk, but this is the reality. And the goal is 10,000, but the reality, and these are data from Germany, 2,700 steps we are walking per day. We are built to walk 36 to 39,000 steps a day. We are not using this machinery anymore. And this is part of the increase in prevalence of diabetes. If I ask the question the other way around, how many hours per day we are physical inactive, this is the answer. We are a lazy species. We are a lazy human race or human being. And this is the main part of the problem. If we are using the power of physical activity not anymore, and this is a problem worldwide, yeah, we should not wonder why we are getting chronic diseases, because we are not using the machinery to burn energy, to keep our muscles alive, to keep our body healthy. And by not doing this and actually seeing this as a quality of life, we accumulate chronic diseases. But we are physicians, we are scientists, we have to understand pathophysiology. And this, what you see here, is healthy. CGM, 1,440 measurements of glucose per day, 24 hours, a young woman with a high normal A1C. And the green arrows mean she is eating something. And the purple line is glucose, and there is nothing. There is a flat curve. And today we know this is very insulin sensitive. This woman needs about 1% of her insulin to regulate blood sugar. But here's her father. It's truly her father. And you see actually a better A1C than the daughter, but you see a totally different curve. And in the morning, in the evening, it's the same like for the daughter, but then there is a fluctuation up and down of glucose in the totally normal range. And why I'm showing this? Because today we know that this fluctuation are actually the driver for morbidity and mortality in people living with diabetes. But it already starts in a normal glycemic state because A1C of 5, we would count this person as being healthy, but he's very insulin resistant. He needs about 80% of the insulin to regulate blood sugar, and this generates this fluctuation. The problem is we don't find these people. We cannot give a sensor for screening yet. But I'm very optimistic in 3 to 5 years, we will have sensors for less than $1 for 2 weeks, and then we can do this. And this will disruptively improve the way how we can deliver good quality of diabetes care. But the take-home message is, whatever we do, if we treat diabetes, we should treat to cut down the fluctuation of glucose. We should cut down the high levels and the hypoglycemic levels, the low levels. And by this, it will be of a benefit to a patient. So imagine two people with an A1C of 7, one with mild fluctuation, the other one with big fluctuation. The one with a big fluctuation gets a stroke and a heart attack. The one with a mild fluctuation may not even need an intensive treatment. So this is the logic behind the accumulation of fat in the liver, insulin resistance, and the fluctuation of glucose variation. And if you are looking into the drugs, what are doing this? It's mainly metformin, DPP-4, and SGLT2, who are brilliant in reducing fluctuation of glucose. And this is the glycemic variability. And you see around the same mean, you can have very different fluctuations and the same A1C or the same mean of glucose, but those with the higher fluctuations have a higher micro and macrovascular risk, so higher morbidity at the end, also mortality. And here, actually shown in an SMBG recording over 15 days of some patients. And again, you see the fluctuation here in the nearly green range, and here the fluctuation with a lot of hypers and hypos. The frequency is about the same, but the value is different. And but the mean blood glucose is the same in both cases. So the fluctuation, the up and down of glucose around the same A1C makes a big difference for our patient. It generates oxidative stress, it generates a metabolic memory, so the body will not forget phases of high fluctuation of glucose. And if you look only into the range of fluctuation here and here, this is much higher, and this big amplitude is the problem for our patient. So again, the logic behind this is we have to reduce the fluctuation if you want to give the patient an optimal treatment. And as I said, this glycemic variability increases oxidative stress. By this, it increases the risk of complications. And at the end, this increases morbidity and mortality of our patient. And this is our goal. We are treating diabetes because we know by lowering A1C, we prevent cardiovascular events. And now we have a better understanding where these cardiovascular events are coming from. This is the glycemic variability. And so you have, with a higher variation, you have a higher risk of hypoglycemia. Of course, if you go up high and low down, this is the hypo. You increase the risk of cardiovascular disease. This is mainly due to the high levels. You increase the mortality rate. And of course, you reduce quality of life and the well-being of the patient. And it is going beyond. Initiating increasing oxidative stress has multiple facets, also for comorbidities of people living with diabetes and high glycemic variability. And now if we are going into it again, and I mentioned already these 3 classes of drugs who are efficient there, what are the at the end, the best combination or the best drug in reducing the glycemic variability, and this is DPP-4. Yeah, SGLT2 is also having a good effect, metformin as well. But if you compare here DPP-4 versus SU and DPP-4 versus the glinates as SU again, and total and to DAPA, you see the values here. And actually, the slide I showed you with the variation, this is coming from a DPP-4 study done with Sitagliptin. And this is, in the moment, the best way of reducing the fluctuations of glucose, but not alone. So the question is, how can we improve synergistically the effect in reducing glycemic variability? Because as better we are to reduce glycemic variability, as better the outcome short-term and long-term for our patient will be. And here you see a very easy to read slide, and you see the 8 classes of drugs we have, and you see all the effects and side effects of our diabetes drugs on it here. And here it's the metabolic effects. Green means good, red means bad, and gray means we don't know. And so the first column is lowering A1C, and you see all, of course, our diabetes drugs lower A1C. But already, if you're talking about hypo and insulin resistance and hepatic insulin resistance and so on, the situation changes. And here you see all cardiovascular effects and side effects. And now imagine I'm your diabetologist and say, yeah, we have to treat diabetes. And I want to give you the drug in the second line. Yeah, I think no one wants to have these drugs. And these are sulfonylurea. But the first line looks very promising. And also here, the DPP-4 line looks very promising. Of course, GLP-1 as well, but it's injectable, and SGLT2 as well. But if we look into the reduction of fluctuation of glucose, there are 2 drugs in combination, metformin plus DPP-4, who actually have potentiate the effect to each other. And it makes sense. Yeah, if you have a drug which it pushes insulin secretion in the moment where you have a meal or the glucose load is coming on, of course, this is of benefit. In the same time, if you reduce the output of glucose from the liver, and if you address the insulin resistance in the liver, and also peripheral with metformin, then you have a synergistic effect. And I would say this is a very interesting combination if you're talking about reducing glycemic variability. Combining this again, if you're looking at SU, SGLT2, and DPP-4, the DPP-4 is the winner in the championship about glycemic variability or reducing glycemic variability. And it's a very safe and tolerable drug. But the main question is this short-term or is this long-term? If you're looking into the story of sulfonylurea, you have very, very good effect over the period of maybe 6 or 9 or 12 months. And then you often see an SU failure. And so this is actually what we don't want. We don't want to give a treatment where we have a short period of effect. And then after a year or 2, we have to change again. And this is cool if we are talking about DPP-4, that the sustainable or the duration of the effect is ongoing, because by reducing the fluctuation, you reduce the stress for the beta cell, and you have a kind of protection and better survival of the remaining beta cells. Because we have to keep in mind, if we diagnose diabetes, often the patient has lost already many of its beta cell, and it is in reduction or decline of insulin secretion. So if you start early with an intervention to reduce the glycemic variability, you have a long effect on improving beta cell function and also insulin resistance and insulin sensitivity. So we could ask, what can we do with this? Yeah? I mentioned it already. Why are we treating diabetes? Because we reduce complications related to diabetes. We know reducing A1C reduces cardiovascular outcome. The question where the cardiovascular outcome is coming from, we answered from the glycemic variability. Now the question would be, what would be the optimal way to treat, or what combination would be optimal for this? And let's start with WHO. And WHO is very clear. Every 80% of our patients with diabetes should be diagnosed, and 80% of them should have an optimal glucose control. And we are far, far, far away from this. And this is not only because we are not using the right drug, it's also related to adherence and compliance of our patients. So we often perceive that if we prescribe a drug, the patient is taking the drug, but this is often not true. Studies show if you give 4 drugs to the patient is only taking 38% of the pill. So the adherence to the prescribed regimen often is a barrier, a big barrier for outcome. So we also have to think about what can we do to improve adherence for our patient. Furthermore, blood pressure control, statin are WHO goal, and having access to affordable insulin for type 1 patient. But let's focus on type 2 management. If we prevent, or if you want to prevent complications, it is not enough only to look at blood sugar. It is important, but we also have to look into blood pressure, lipid management, and cardiovascular and kidney aspects. And I jump back to WHO. This is exactly what WHO is saying. We have to diagnose them, have a good glycemic control, good blood pressure control, and a good lipid control for our patients. And for me, this only can be achieved by applying the polypill concept to our patients. So if the ideal situation would be that once a day the patient is taking 1 pill, and this is helping to cope with his chronic disease. And we have a lot of options. Yeah? We can treat diabetes in 8 different tissues. All the different drug which we have available. And one of the winner, I would say, is always metformin. Yeah, it's very old drug, but it's not the oldest. Yeah, there's the first discovery of a molecule, what we can call SU, was a year before metformin. But metformin is already 102 years old and was first developed to treat influenza. Then it became a diabetes drug, and today it's not a diabetes drug anymore. It's an anti-aging, well-being, longevity drug. So actually, any one of us should take metformin to reduce cancer risk. But what we know from UKPDS, it improves all-cause mortality and myocardial function of our patients. And the importance is myocardial function and all-cause mortality is cardiovascular outcome. And cardiovascular outcome is what we want to improve. And the cardiovascular outcome comes from the glycemic variability. So survival of metformin users is a higher probability to survive with metformin compared to other diabetes treatments, mainly SU in this study. And here is the cancer survival for people having metformin. And you have a substantially reduced cancer risk for people having metformin. This is what I always like to say. If you take metformin, if every one of us would eat metformin, we would live longer because we have a reduced cancer risk. And this is especially interesting for people living with type 2 diabetes because of the insulin resistance. They have a higher cancer risk. So metformin is a very cool application for our patient. Then the DPP-4 inhibitors. You know the function of the DPP-4 inhibitors. It's a very clever concept, not generating hypos, initiating an additional insulin release in the moment where there's a glucose load coming. And if we look into the monotherapy or add-on therapy of metformin, they have a very robust, sustainable reduction of A1C in combination with other drugs or as monotherapy. So this is something we can rely on if we treat. If we combine the effect of metformin with DPP-4, this could be a cool step ahead in terms of durability and reducing glycemic variability. If you compare all the different DPP-4 inhibitors, you see a very good effect on Sitagliptin, but many of them are very comparable to each other. And if you then look into, I apologize, into a patient case and look into the challenges we have to address in terms of treating glycemia with the goal to prevent cardiovascular disease, but having the momentum of the adherence of the patient also in mind. There is a 56-year-old man who has diabetes since 3 years ago, probably much more than 3 years, because diabetes is diagnosed late. He is treated with 1000 milligram metformin, so not the maximal doses, has a stable A1C, but then the A1C went up to 7.6. So you probably say it's not very high, but it's far too high if we would call our goal in diabetes management a near normal A1C of our people living with diabetes. And he has postprandial peaks. So he has this increase of glycemic variability, and sometimes he is also having hyposymptoms. So also he has having the low. And here we see already clinically, we can identify those people with a higher glycemic variability if they have, for example, postprandial spikes, but sometimes also have a hyperrisk. Summarizing this is exactly the patient who has a very fast evolving cardiovascular risk by the increase in glycemic variability. And we would say a short duration of diabetes already. And we have a case here where metformin is not able alone anymore to reduce the fluctuation. Metformin has a good effect on reducing the fluctuation, but not in this case anymore because the secretory capacity of the beta cells is going down. And metformin alone in the medium doses cannot maintain stable glucose level. So the logical consequence would be adding DPP-4 and adding Sitagliptin in this moment, keeping the metformin and updating the prescription and medication plan. And an interesting approach to confirm this would be using CGM before and after the therapy. I know that this is difficult, but not in a few months or years anymore. Yeah? So having a CGM and looking into the glycemic variability, and you see that the time and range actually is low. This is the right patient in the right moment with a good argument to give a treatment to reduce the fluctuation. And if you have CGM also afterwards, you can control, is it effective? You can do it immediately, giving one sensor for 2 weeks and starting 7 days before, then changing treatment and give it the patient. And what we see in our environment in Europe, that having the sensor increases in compliance a lot for the patient. But you also can do it, you use a sensor and for 2 weeks, then later you change therapy, and after 3 months you test this again. Again, I understand that using a sensor in your environment is still challenging, but this will very fast change in the future. And here you see, I apologize, this slide, that this bars are so reduced here, but what I wanted to show, we have a clear reduction of the mean amplitude of glucose excursion from 5 to 3.7. So a significant reduction of the amplitude or of the glycemic variability, and an improvement in time and range. 78%. It's not optimal yet for a healthy individual, because we would say health means 97% time and range, but the goal for diabetes management is 70%. And so we already after 4 weeks of treatment with the combination of Sitagliptin with metformin, or the add-on of Sitagliptin to metformin, we were able to improve the glycemic variability for the patient, and by this also the long-term outcome for the patient. If we look into the time frame, you measure the baseline A1C, you change the therapy you measure continuously A1C again, and we can expect in this case, in this person with an A1C of 7.6, increase over 12 months, we can expect that we have a very good evidence for therapeutic glycemic durability, um, uh, so that we can up to 3 to 4 years expect here a good outcome. And the good outcome is not mainly coming from a better A1C, it's mainly coming from a reduction of the glycemic variability. Now the aspect, how can we improve this for the patient? And this for me is the polypill concept. Because giving it at one pill at the same time, or not as two separate pills, we might actually have also a reduction in adverse event. It may sound odd because you give the same dosage, but you might reduce the side effect. You have improved patient adherence and satisfaction, and a better adherence to therapy and outcome for the patient as well. So if we talk this in terms of innovation or the art of care, as I said it in the beginning, we can call it the clinical pearls we have by giving a polypill of the combination of sitagliptin and metformin, that we significantly improve the efficacy of our treatment by reducing the fluctuation of glucose. And this maintains a long-term good glucose control over years. And of course, the patient has a lot of benefits. Yeah? We had a patient with hyperglycemic postprandial spike and hypo events, also as a type 2 diabetes patient. And we will cut off both. So better glycemic control and better quality of life and perception. So the combination of Zita with metformin is safe, it's clinical proven, and has a targeted effect of reducing glycemic variability. And this bridges our therapeutic management from having patients with a high cardiovascular risk by the fluctuation of glucose into an adequate management of diabetes. So this is coming from by sitagliptin, by enhancing prandial insulin secretion, metformin improving insulin sensitivity. And these are two synergistic dual effects adding to each other, which you do not have with some of the other combinations of diabetes drug. But in this case, DPP4 plus metformin is very effective. Also, the benefits are complementary by improving insulin sensitivity and by this reducing glycemic variation. And then a prandial insulin secretion is also targeting the insulin to the need. So you have not an over secretion of insulin due to the fact that you had hyperglycemia. And by this, you're reducing the frequency of hypos. And this is combined and synergistic for our patient. The clinical evidence, it reduces the MAGE, so the mean amplitude of glucose excursion. This is what we want to reach to reduce cardiovascular risk. If you have a CGM, you can show it also in time and range. This is a more modern parameter, but we need cheap sensors for this. But the time and range is something the patient says, yeah, I don't care about the time and range because I don't feel it. But what he feels is the hypoglycemia. By reducing the hypo events for the patient, it's immediately a benefit for the quality of life. And this is backed up by numerous clinical trials showing that the combination of metformin plus sitagliptin is of benefit. What are we reaching over here 4 years in this case? Better A1C control, better A1C reduction. We have actually tested in clinical trials 4 years, nearly 4 years glycemic control with the combination compared to not having the combination. So we have a clear improvement in the outcome for our patient. And this is backed up by a better glycemic control for our patient and clinical relevance for the management following our guideline. Practical implication, a good duration of treatment, reduced fluctuation of glycemia, and clear benefits for our patient. So the patient is benefiting in terms of cardiovascular outcome, and also the patient is feeling the effect. Why do we need the International Diabetes Federation? Why do we need IDF? And I want to make a very clear statement. We need a powerful voice for us as healthcare professionals, but also for people living with diabetes, to do exactly what we do here now, to learn about the best quality of diabetes care and learn about how we can push this quality of diabetes care into the last mile of reaching the patients where they are living. And I truly believe that every person with diabetes has the same right to get the same quality of education, treatment, diagnostic, and preventive measures. But the big challenge worldwide is accessibility and availability of diabetes care. And also here, every person with diabetes has the same right to have the same accessibility and availability of diabetes care. And for me, as president of the International Diabetes Federation, I have three goals. And I want to be in the head of every health politicians in the world. I want to be in the pocket of every diabetes patient, and I want to be in the heart of every diabetes care provider. So this is you listening to this. How do we want to reach this? We will develop a global diabetes index, and this index will be based on asking patients and healthcare professionals in every country in the world once every year. And this is 121 questions, and the answers to these questions we will translate into an index. And this index will be freely released 4 weeks before World Diabetes Day. So it's a 0 to 100. And by using this index, you immediately can make the quality of diabetes care comparable between Minnesota and Berlin and Faisalabad. And this will help us to have a kind of indicator how good we are in delivering diabetes care, how good our structures are, our policy is, our education is, our diabetes care practices. Secondly, I want to be in the pocket of every diabetes patient. And you can imagine using smartphones, using digitalization, and providing a freely accessible diabetes education program could be a game changer in enhancing adherence, enhancing education, enhancing self-management for our patients. This is where the International Diabetes Federation is working on. And finally, the IDF fellowship program. IDF has developed a fellowship program, and this is a fellowship program for you as healthcare professionals. And you are invited to become fellow of the International Diabetes Federation, because together with you, we might build a global community of actors to improve the quality of diabetes care, a global communities of actors who are able to do whatever we can do to improve the quality of diabetes care in conjunction with the diabetes team, together with our patient. So a passionate workforce to improve the quality of diabetes care. The International Diabetes Federation is getting 75 years of age, and it's an old organization, but it's a very experienced organization during such a long time, and a lot of experience in different environments, consisting of 256 member organizations. This is an asset we can use to improve the quality of diabetes care. And I would love if you would follow any of these social media channels where I'm reporting about the activities of IDF and where I'm inviting you to become part of this large community to improve the quality of diabetes care worldwide. So don't forget these faces of people living with diabetes. I think our obligation as healthcare professionals is doing whatever we can do to put a smile on these faces of people living with diabetes, because they deserve a better life. And for people living with type 2 diabetes, this would mean improving the quality of care by reducing glycemic variability and by combining metformin with DPP-4, and using metformin together with sitagliptin would be the right approach to increase the outcome for our patient, reducing cardiovascular risk and by reducing glycemic variability. So let's work together. Let's do whatever we can do together to join our forces to finally help our patient to walk away from diabetes. Thank you very much. Shukran. Thank you very much for your attention.